I'll be running the cervical disc arthroplasty case. I'll have a talk on cervical disc herniations in athletes and then present one. I actually have two cases that if we get to, we'll have time for. Yeah, first things first. So these are my disclosures. None of them are pertinent to the topics of this discussion. It's clear that when we treat a C6-7 disc herniation in a 59-year-old female with weakness, it's significantly going to be different than a 24-year-old who is a wide receiver and has their livelihood dependent upon any subtle weakness of the arm. But the question or the issues that come about are real, because the risk-benefit ratio for somebody with a catastrophic spinal cord injury versus someone who's allowed to get back onto the field and win a Super Bowl, these are real issues, real cases, and the decisions we make have real consequences. We have to remember that the solutions to the clinical problems and even the case that we're going to be talking about, there's really no level 1 or 2 or registry data that's available that will help us answer the question. So we're really relying upon level 3, level 4, and even level 5 data that certainly can come in handy when we talk about consensus and what to do. Back in the days when Darryl Stingley had a spinal cord injury, Mike Utley in 1991, we had very, very little data to guide us. And nowadays, it's much better. Still not end-all, be-all, but in 2023, we have over 30 studies to sort of guide us as to what to do with these individuals. The way I think about return to play criteria is really a four-pronged approach. Not only the individual's clinical presentation, physical exam findings, but also what the imaging shows, and then finally the type of sport. Clinical presentation when it comes to cervical injury really comes down to determining if somebody has transient quadriparesis versus a stinger-like episode, because there can be some overlap in these symptoms. Clearly somebody with either myelopathic symptoms or upper motor neuron signs of physical exam really should not be getting back to play. Most individuals would not allow someone to go back to play if there's a T2 signal intensity that has not resolved on a cervical MRI. And then finally, the type of sport really matters when you're talking about a cervical versus a lumbar issue. In particular for cervical cases, it's important to distinguish between contact and collision sports. And this can have a bearing on return to play, on prognosis, and on even treatment, whether somebody gets a disc replacement or not. When it comes to the athlete's cervical spine, there are many controversial topics. I'll address some of these, but focus the talk on motion-sparing technology, which has been a more recent, interesting topic, I would say. The NFL certainly represents a high-risk population that we have case studies and case reviews that allow us to make determinations, because there are many different unnatural loading patterns on the players if and when they get back to play. And certainly this is the most stringent sport, in my opinion, when it comes to looking at whether or not a cervical disc herniation can return to the field. We have very good data to show that disc fusion or anterior cervical discectomy fusion can lead to very high return to play rates. And if you look closer at the data, the success, and not the incidence and the success rates of getting back, really depends on the position. And this can be applicable to a number of different sports that we think about. However, when we're talking about a collision sport, and in particular American football, rugby, and even boxing, these kinds of sports, we have to be thinking about the stringency in terms of, and the thresholds as to how to return these individuals back. But with a sport like football, there's so many varieties of positions, and when you've got somebody who's weighs a lot less than 30 or 40 pounds less than an individual who they're trying to make a tackle on, the implications of the fusion are real. And so this may represent an opportunity for newer technologies such as disc arthroplasty. Now, the natural history of this issue also should be talked about, because if you are convinced that a disc arthroplasty has a different prognosis in somebody with a C5-6 disc arthroplasty versus C3-4, then it becomes real in this population, because in this particular collision athlete population, we've done studies on these, we've shown that although the general population has a much higher incidence of this problem as C5-6 and C6-7, when you're taking a collision athlete, you're talking about an upper level issue. And so there certainly can be implications with how to treat this, and it's still unknown whether or not the disc arthroplasty can improve that particular case. A number of options are available, and we'll sort of discuss that with the case presentations, but not only fusion or disc arthroplasty, but we can also do foraminotomies. Studies from my group early on have showcased that all three of these options are realistic possibilities for elite athletes, even those in the National Football League. And so one just has to know that the higher return to play rate is with a foraminotomy, but the higher reoperation rate is also with this group. And the performance in general, though, is not affected either case that you choose, even though in our particular case series at the time there were only 2 individuals with a disc arthroplasty. This is not new news, because if you look at the general population, the reoperation rate is relatively high in the young, active individual. But it is important to know that these individuals who go on to have a fusion do not have a poor outcome. And I'll skip over this. So disc arthroplasty certainly presents a very interesting case, because we have athletes who don't do very well from fusion. We know that motion is better than fusion. We know that patient-reported outcomes may be improved. And the hope is to reduce the operation rate. Now, in general, these statements are true for the general population. However, the knowledge base for individuals who go back to professional athletes is somewhat unknown. This has come to the forefront because of this individual. Jack Eichel is an all-star NHL player who forced a trade from one team to another because he wanted a disc arthroplasty and not a fusion. He ended up being traded to the Vegas Knights, got the disc arthroplasty, and then won a Stanley Cup later that year. And so this is now referred to as the Jack Eichel surgery in many groups, because this has led to a number of different athletes and physicians and individuals sort of asking about it and whether or not it is applicable or not. In response to this, my research group looked at all of the reported cervical disc arthroplasty cases that have been reported in the literature in high-profile athletes. They're all listed right here. You can see that there are a number of elite contact athletes versus collision athletes. And the bottom line is that there have been no complications reported, meaning that this is likely safe in a number of different sports. There is one collegiate football player that has been reported having a disc arthroplasty in this case report and has returned to play 8 weeks afterwards. I will tell you, though, that the National Football League likely does not employ a physician that would allow a patient to get back. As it stands right now, it doesn't mean that that would change, but it does affect how we counsel college athletes who are looking to make that next step. This is what we want to avoid, right? And certainly this is just one implant in a case series, but osteolysis-induced aseptic failure, if it occurs in the general population, would certainly be a higher rate in this particular patient population and can have drastic consequences. So in general, I think that the biomechanical testing, especially even in preclinical studies, have shown that this can be stable with head impact repeatedly. We know that general patients and MVAs do not dislocate, and the clinical and anecdotal evidence does support the use of TDA in these athletes. However, in particular in National Football League, the forces are somewhat different. Again, as noted, the NFL physicians are wary of clearing patients with disc arthroplasty right now. And the question always comes, do you want to be the first individual to clear your patient to get back, knowing what is possible, both good and bad, I would say. For a 2-level disc arthroplasty or disc herniation, I do think a 2-level fusion is consistent or compatible with return to play, in my opinion. Not everybody agrees with me. For a pseudarthrosis like this patient who has a C3-4 ACDF without a bony fusion, in my opinion, if you look at pseudarthrosis in the general population, only a subset are asymptomatic, and we know that these asymptomatic pseudos do not necessarily need treatment. And the concerns of the collision athlete really come down to hardware migration, risk of spinal cord injury, and risk for further surgery, of which the studies seem to suggest that this is very, very low probability of it occurring. So in my opinion, pseudarthrosis patients can come back. Now, I'm not, I may be alone in this, because if you look at the consensus of individuals or spine surgeons in general who agree on returning to play, there's some things we agree on, but other things we don't. And certainly the discussion, these panel discussions that we're talking about will hopefully elucidate more of that. We published a study that sort of reviewed a lot of the topics that I just talked about in terms of what the outcomes would be. I do think that the disc arthroplasty population is evolving as we speak. And so, the real question, or the real issue here is that as data increases, we need to sort of change the way we look at different questions that come about. I never answered disc arthroplasty questions so frequently now as I, compared to 5-10 years ago for sure. And we really should individualize this treatment not only to our general population patients, but also the athletes that come to see us, and to be consistently evolving the way we figure these things out. Thank you.